So, today we are going to discuss about asthma, everything you need to know about asthma related to MRCP part 1. So, let's start. For asthma, there are 4 or 5 separate categories of asthma that we need to remember. First is acute exacerbation of asthma. We need to know about this. Second, occupational asthma. Third is we get some MCQs for cough variant of asthma, and last is chronic asthma. The other one, uh, sometimes we do get some MCQs of brittle asthma. Yeah, so we will discuss that in the end. So first, let's talk about acute asthma. Ideally, we should discuss the actual chronic asthma first, but that is a bit lengthy. So we will just cover acute exacerbation first, and then we will go and discuss the other one. We all know what is acute exacerbation of asthma. If someone who is non asthmatic mostly, they can get this acute exacerbation due to any viral infection or any other upset in the body. So, clinical symptoms that we can see in them is shortness of breath, wheeze, not responding to the medication that they usually take, or triggered by any infection, as we discussed. So, now we have divided acute exacerbation into further 4 categories of asthma based on the severity: moderate, severe, life threatening, and near fatal asthma. To be honest, it is always difficult to remember, which category it is. So I have tried my best to simplify them. We need to remember the figure from 25, and we will keep multiplying by 2: 25, 50, and 100. We need to remember these 3 words. We will start with severe acute exacerbation of asthma. Let's discuss this. First of all, as we said, 25, respiratory rate more than 25, peak expiratory flow rate less than 50, ideally 33 to 50. But to simplify it, it will be less than 50. And heart rate should be more than 100. Some say it should be more than 110, but the idea is the patient will be tachycardic, and the tachycardia definition is usually more than 100. So severe is respiratory rate more than 25, peak expiratory flow rate less than 50%, pulse rate or heart rate 100, RR, PR, PR. Patient will not be able to complete the sentences, we all know. Moving to life threatening acute exacerbation of asthma. Again, to simplify this, peak expiratory flow rate will be less than 33. We all know this is nothing new. And all the other signs. So this is the triangle which cover head, lungs, and heart. Related to head, what will happen? Coma, confusion, drowsy. Related to lungs, hypoxia, poor respiratory effort, silent chest. With related to heart, arrhythmias, hypotension. So these will be the signs for life threatening. Moving on to near fatal asthma. The only thing with near fatal asthma is it is obviously the acute exacerbation of asthma, but the only difference is after treating the patient, when we check the blood gas, his uh, PCO2, the carbon dioxide pressure, will be normal or high. Usually, because of hyperventilation, their PCO2 is always less than normal. Normal is 4.5 to 6, or some say 4. So normally it should be around 3, 2.9, 3.1. But if it goes up to 4.5, 5.5, or above 6, if it is above normal or normal, then patient is categorized as near fatal asthma. Most important, we will discuss later. There are multiple MCQs related to this. Coming back to moderate, same figure, 25, 50 or 100. So we will just remember this. Respiratory rate less than 25, here more than 25. PR, peak expiratory flow rate, more than 50. So we are talking above 50. And again, PR less than 100. So as we can see, we just need to remember severe category, and it will help us to, you know, remember what is the reading of moderate. Not that important though. So let's talk about the management. So all these things which are written in green, we will discuss later. These are all the MCQs usually. So for management of acute exacerbation of asthma, we all know we start with oxygen. Aim 94 to 98%. It should be 15 liter with non-breathable mask. Usual stuff. The next step is salbutamol. We usually nebulize them 2.5 to 5 milligram at 15 to 30-minute interval. If we don't have salbutamol, we can go with terbutaline. Usually it is double the dose of salbutamol. Next, steroid. Usually we give 40 milligram. It is milligram. 40 milligram per oral prednisolone. Or if we want to give hydrocortisone, the dose is 100 milligram. Or if we have methyl prednisolone, we give 160 milligram. But we don't need these two. This is fine. So oxygen, salbutamol, steroids. Next is, if patient is not better by this time, not improved, we need to step up the game. We will add ipratropium, zero point 0.5 milligram or 500 microgram. We can repeat 4 to 6 hour daily, 4 to 6 hourly. Next step, if patient is still not improved, we can go for magnesium sulfate, 1.22 gram IV over 20 minutes. Aminophylline, 5 milligram per kg. If patient is 70 kg, then we need to give 350 milligram. Again, for MRCP1, this is the maximum level we need to remember. Most of the MCQs will be, they will give these two steps and they will expect you to answer this step, or they will say we have given steroid, ipratropium, and they expect us to answer this. That's all we need to remember from here. Yeah. So acute exacerbation of asthma is finished. Let's quickly go through the MCQs. So near fatal asthma. So there was an MCQ. Let me use this, which explained patient came with acute exacerbation of asthma, previous admission to ITU, multiple admission to hospital, and now we have given everything to the patient, including magnesium sulfate. but on blood gas you see normal carbon dioxide. What will you do? So there were multiple options. Suppose the options can be repeat steroid, maybe do some NIV, but the right option is this is the time to escalate it to ITU for ventilation and intubation. Different type of MCQs that can come, they will give you the same or a slightly different scenario. With ABG, we can clearly see the carbon dioxide is above normal, which is alarming. So patient is in near fatal asthma. So we can remember these values. The oxygen pressure will be less than 8. pH will be acidotic 7.20, less than 7.35. We need to look for this. The other MCQ that can be asked is, after full treatment, what is more worrisome feature? So again, normal PCO2. Okay, coming to the steps of management. Now we know oxygen, salbutamol. We can change it to terbutaline to double the dose. Steroid we know 3, but we only need to remember 1. And fourth step is IV magnesium. Sorry, after steroid, ipratropium, and then next IV magnesium. So MCQs related to this: if patient is coming in with acute exacerbation of asthma, what is the first medical management step? Oxygen we have given. First step is to give nebulization 2.5 milligram. Other variation can be, so a young female usually presented with acute asthma, nebulization has improved peak expiratory flow rate. What is the next step? So nebulization has improved the patient. Next step is, we all know, steroid. Next, a female, young female, usually on seretide and salbutamol. Seretide and salbutamol. What is the next step? So now here, seretide is basically a malt regime. We will discuss what is malt regime. Patient is a chronic asthmatic on malt regime, maintaining the symptom of chronic asthma. And now patient is coming in with acute exacerbation. So we need to kind of remove this from the question and our mind and only focus on what has been given for acute exacerbation. We have only given salbutamol, oxygen, and the next step is steroid. So for ipratropium, to be honest, not a lot of MCQs usually come, because either they want us to remember these first two steps, or what will happen if patient is not improved. Magnesium sulfate is very important. MCQs can be young female with peak expiratory flow rate very low, 37. Patient had nebulization, oxygen, steroid, still wheezy. What we need to do? IV magnesium. Other patient has known to have brittle asthma. We will discuss brittle asthma. And we have given SABA, salbutamol, steroid, slight improvement in peak expiratory flow. So what we need to give? IV magnesium. So I believe by now we know acute exacerbation of asthma. Always in asthmatic, wheeze, cough. We know severe, life-threatening, near fatal. Severe, 25, 50, and 100. If it is severe, above 25. If it is, we are discussing severe, 100, above 100. Peak expiratory flow, 50, below 50. For moderate, we will, reverse these patterns. Speech will be normal in moderate, and in severe can't speak. For life threatening, we have made this triangle: for head confusion, drowsy. For lungs, poor respiratory effort. Silent chest is the classical thing for heart arrhythmias and bradycardia. So yeah, here it is written bradycardia. Near fatal, we know most important, very important thing, normal raised PCO2. Multiple MCQs we have discussed. Management O2, salbutamol 2.5 or 5 milligram with NEBS, steroid 40 milligram, prednisolone, and we don't need to remember the other one, hydrocortisone or methylprednisolone. This 400 is basically the hydrocortisone daily dose. Ipratropium, magnesium sulfate, multiple MCQs. So we are sorted with acute exacerbation of asthma. Good. What is this? After above management, if PCO2 is normal or high, so yeah, discuss with IT. Moving on to next, asthma, which we usually see in MCQs, occupational asthma. Nothing different. It is asthma, but multiple MCQs usually come. Patient will be non-asthmatic or could be new. So patient will be concerned about ongoing shortness of breath, cough, usually at work. So there will be two classical words in the question. Something is worsening at work, feeling better on holidays, feeling better on weekend, feeling better while leave the work. Okay. And something is getting worse, shortness of breath, wheeze, cough, patient is not feeling good on work or during the weekdays. It can also be like during weekdays. Now, so feels better on holiday, exposure to following chemical can cause these symptoms, cough, wheeze. We will discuss these now. But before this, very simple. What is the management? Just a moment. Hmm, yeah. So management for occupational asthma, one word: serial peak expiratory flow readings at work and home. Then refer to specialist. The reason we need to do this, we are not sure if the patient is having asthma related issues. When we get the peak expiratory flow variation, we can say, okay, this is occupational asthma related to work. Symptoms can be triggered by NSAID or beta blockers. It is not related to occupational asthma. This is just simple. Any asthmatic patient on beta blocker or NSAIDs can get some worsening cough or worsening asthma symptoms. MCQs can be a patient, comorbid condition, non asthmatic, already on the controlled regime for asthma. Now he has got an MI, and the doctor has started the usual regime of MI, including beta blocker, atenolol. Patient is feeling much worse now. Which medication you will stop? From this, now we know. Another MCQ from the same line: patient was involved in a accident recently, is on NSAID. Symptoms are getting worse. Which medication you will stop? We know NSAID, ibuprofen, naproxen mostly comes in the MCQ. MCQ. So catering. Yeah, let's talk about the chemicals. Most common, isocyanate. This is the most important to remember. Isocyanate, used in paints. Anyone who is working in painting industry, they can get isocyanate exposure, and then they can feel occupational asthma. Features of asthma getting worse. Other names: platinum salt, soldering flux resin, epoxy resins, proteolytic enzymes. So for isocyanate, question can be most common agent. If someone is working in laboratory worker, animal feces exposure, and they can get occupational asthma. And then, as we discussed, spray better on holidays. Now we know all this. So this is the mnemonic. I didn't find any good one, but LMF, 4 Ws. But we don't need to remember. We can make our own, or whatever you feel comfortable. L for lab animal worker, M for millers or grain handlers, F for farmers, 4 Ws, workers in 4 categories: coating industry, metal refinery, washing, and welders. Uh, for from paper point of view, we need to remember bakeries. The other one, coating industry, painting industry. The third one, we need to remember lab workers, so they can get exposure to multiple things. So working in catering, bakery, cough wheeze, going on for 7 8 months, symptoms better on holiday. What we need to do? Cereal, peak flow. Other 40 50 year female working in soldering plant, intermittent cough wheeze during work, raised ESR will be raised, nothing related there. What we need to do? Serial peak flow, as we discussed here. Serial peak expiratory flow readings at work and home, and then refer. That is done. So now we know about acute exacerbation, occupational asthma, acute exacerbation, symptoms: O2 salbutamol, steroids 40 milligram, ipratropium, magnesium sulfate, then aminophylline, but that is beyond the scope of MRCP1. And types, near fatal is most important. CO2 will be normal or raised. If you see CO2 normal in any asthma related history, that is an alarming sign. Escalate for intubation, ITU discussion. And then 25, 50, 100 figure for severe, more than 25, more than 100, less than 50. If we say less than 50, we know 33 to 50. For moderate, less than 25 respiratory rate, less than 100 heart rate, and more than 50 to 75 peak expiratory flow rate. For life threatening, we have made this uh, triangle to remember all the symptom of the lungs, heart, and brain. So the reason I am repeating all those things, to be honest, after this, I really want all of you to just open the MCQs and be confident. You don't need to read the theory or go through MCQs, just do it. Occupational asthma, we know symptoms will get worse during weekdays, on work, feel better away from work, on holidays, during weekends, and then management, serial peak expiratory flow, home. The only thing, there are multiple uh, agents that can cause iso. Cyanate is most important, and then history will be catering, bakery, industry, or soldering plant. So the answer will be serial peak expiratory flow. Two things sorted. Coming on to third one, cough variant of asthma. Now this is not basically related to asthma. It is just something to keep in mind. Usually, mm, it can be asked in MRCP part one. When someone gets a feature of asthma, or if asthma is starting, the very first thing they will get is inflammation of their airway. That will be followed by bronchoconstriction, which is actually the chronic form of asthma. But in the start they get uh, airway inflammation. we can see here, or irritation. Some people don't have bronchoconstriction, they only get airway inflammation. Now, clinical feature, obviously, it is an asthma. Same features, dry cough, ongoing for longer period of time, worse on walking or waking up in the morning. The other interesting thing, which can be misleading in this, all investigations, including examination, auscultation, no wheeze, chest X-ray, no hyperinflation, pulmonary function test, no obstructive spirometry, peak expiratory flow rate. I have not written here, but we can. No variability. We will discuss these in the next chronic full asthma. Everything will be normal, but patient is still getting this ongoing cough, waking up in the morning, going on for 7 8 months. Now, the options, there will be multiple options from the management perspective. If we see only these two things, clinical symptoms, which is cough, wheeze, ongoing for some time, sorry, and then the second thing, all the tests are normal. What will be the best management? Trial of high dose inhaled corticosteroid for 2 months. This is the answer. If we don't want to go for ICS, we can go for oral steroid short course. Yeah, oral steroid short course. So again, MCQ can be elderly female with dry cough, wake up at night, all the tests are normal. So we are done with cough variant of asthma. We are done with occupational asthma, isocyanate, isocyanate, industry important, holiday, all those things. Coming back to here, we know triangle, we know features of severe asthma, can't speak, speech normal, 25, 50, and 100. Moving on to asthma, the chronic form of asthma. So here we noted it is asthma, but management is slightly different for each type of asthma. That's why I have separated them by category, because we are expected to tell the initial bit of management. For acute exacerbation, we know oxygen, salbutamol, steroid, ipratropium, magnesium sulfate. For occupational, all we need to do serial peak expiratory flow rate here, and then the referral for cough variant, high dose of steroid, inhaled corticosteroid for 2 months. Chronic asthma, we know actually asthma is chronic inflammatory disease of airway. This is the classical auscultation finding expiratory polyphonic wheeze. To be honest, we have seen a lot of patients in AD here in UK, and we know from the history patient is non-asthmatic coming in with shortness of breath and wheeze and all those things, and you just auscultate and you just tell to your colleague that patient is having wheeze. But if you say expiratory polyphonic wheeze, their mind will be blown. Whoa, man, you must have read something more than me. But it is just a fancy word. Classically, if you auscultate, there are multiple apps. V's for auscultation. It will be multiple high pitch whistling sound. So if you hear, there will be multiple sounds with different intensity of the pitch. So, and during expiration, obviously. Next is for chronic asthma. We are going for chronic asthma. I hope I'm not moving the screen too fast. Chronic inflammatory disorder characterized by hyper-responsiveness of airway. And what do we see in asthma? Airway hyper-responsiveness, airway limitation, airway inflammation. Airway inflammation, different type of test we need to do, we called pheno. Airway limitation, we need to do different type of tests, spirometry, peak expiratory flow rate. We will discuss that now. Airway hyperresponsiveness, we do bronchial challenge test. We know chronic asthma, what is it now? So this bit is important basically. What happens in asthma pathophysiology, hyperresponsiveness, airflow limitation, airway inflammation. Uh, Before going on to management, let's discuss the clinical features. Same as we discussed in every other type for acute exacerbation, chest tightness, wheeze, dry cough, worsening shortness of breath, or dyspnea. This is something more that we usually don't need. It is good just to, if someone is chronic asthmatic, there are simple signs that you can pick to correlate. First, if you see the X-ray, it will be hyperinflation of the chest. You will see the slightly elongated chest X-ray, not as evident as in COPD, cylindrical barrel thingy. And here MCQ usually come patient with asthma. What we will see, increase residual volume, increase residual volume, that is from hyperinflation. The other sign we can see, eczema, we can see the patient has multiple uh, eczema features. Nasal polyp, if patient is sensitive aspirin sensitive asthma, we can see nasal polyp. Tachypnea and expiratory wheeze, obviously we can do this on examination. Clinical feature, nothing new there. Coming on to diagnosis. So let me give you this overview. So here, so this is the diagnosis we are going to discuss, and then here management, yeah, and then we will discuss some terminologies. Before we diagnose an asthmatic patient, we need to know what are the tests that we can do. First of all, pheno. Second, spirometry. Third, bronchodilator reversibility test, BDR test. And then variable peak expiratory flow reading. And then two more tests we usually do, direct bronchial challenge test with E here, skin prick test. We don't do skin prick nowadays. So let's discuss what are they, and then it will be very easy to understand when to use, how to use. Pheno is fractional exhaled nitric oxide. Basically, when we get inflammation of our airway, those inflamed cell release nitric oxide, which we then measure into the breath. So based on the level of nitric oxide, this test either can be positive or negative. So if the level is 40 parts per billion, ppb, in adults pheno is positive. For children it is 35 parts per billion. So this is positive. And then if pheno is from 25 to 39, this is the gray area. If it is below 25, then we don't bother. Then we say consider other possibilities, because if someone having asthma, there has to be some airway inflammation which directly relates to release of nitric oxide. So that was one of the pillar airway inflammation, not that inflation of the currency, inflammation. So now we know pheno, well done, spirometry. The other pillar of chronic asthma was airflow limitation. Because of bronchoconstriction, air cannot flow out freely. And for that airflow, we have two tests. One is spirometry, the other is peak expiratory flow rate. But we will discuss them for now separately. Spirometry, a very fancy machine. We ask the patient to blow into the machine. We will leave that aside how to do it. But the thing that we need to remember, two terminologies in spirometry: forced expiratory volume and forced vital capacity. So forced expiratory volume, one is the amount of air, the volume of amount of air the patient can expire in 1 second, and FVC is total maximum air the patient can expire. If we divide them, it means if we divide and it is less than 70%, it means patient has got obstructive spirometry. For this table, we can also say positive spirometry. It means some obstruction, but usually it is obstructive if it is less than 70%, and it will be non-obstructive or restrictive if it is more than 70%. To give you an example, so suppose this is uh, let me use the other pen. So suppose this is the lung and this is the bronchus. Now, because there is enough room, patient can exhale almost all the air from the lung in first second. Suppose if you have got normal lungs, you can almost exhale all of the volume in 1 second. Suppose if the patient has exhaled 3.5 liter, this is not accurate, but just for the sake of understanding, if patient has exhaled 3.5 liter of air, which is almost the total lung capacity, and then this will be FEV1. The other one is forced vital capacity. Because he has already exhaled all of it, nothing is left. Maybe a little bit of residual after forceful expiration will come out. So suppose it is 3.8. So if we divide these 3.5 to 3.8, it will be more than 70%. It means it is restrictive. Now, if I take a lung and make the passage narrow, the patient will be able to exhale at the end of the day 3.8 liter fully, but it will take him maybe 3 to 4 seconds, and he can exhale maybe 1 liter in first 1 second. These figures are not accurate. This is just to understand what exactly is FEV1 by FVC divided by FVC. So now 1 liter divided by 3.8 liter, it will be less than 70%. No matter what the answer is, but it will be less than 70%. So it means there is some obstruction here. That's why patient is uh, not able to exhale the amount of air in the lungs as quickly. So that's basically FEV1 and FVC. So well, there should be a better way to remove these, to be honest. Technology. Okay, so next we will move on Now we know obstructive spirometry, positive for asthmatic, less than 70%. Next test is bronchodilator reversibility test, BDR test. In this, as we have seen, there is some bronchoconstriction. We give our patient beta 2 agonist or inhaled corticosteroid or oral steroid, which will help to dilate this uh, air tracts, bronchioles or bronchus. Now, what happen in this test? We will give beta agonist, inhaled or oral steroid, and if forced expiratory volume is improved more than 12%, then this test is positive. It means there is some degree of constriction, and now after medication there is some dilation. So this improvement is in FEV1, but if we look on FVC, forced vital capacity, like kind of expired total capacity, there will be an overall increase in 200 ml of volume. Yeah, it should put some V here. So if improvement of 12%, 200 ml of volume expansion, BDR is positive. But if we only see 400 ml of volume expansion, that is still suggestive of asthma. In children, we don't need the expansion bit. If there is 12% of FEV1 improvement, we say BDR is positive. Okay, so we don't need to remember these in details, but if we know the idea, we know where to apply this test, because that will come up in this whole here whole tree, that will be useful. So now we know the test: pheno, spirometry, obstructive, non-obstructive or restrictive. Pheno, nitric oxide. The last one, not the last one, sorry, BDR test. We know now what is BDR test. We will give three agents and we will measure the dilation by checking the improvement in FEV1. Okay, what happened here? So next is variable peak expiratory flow rate. We have all seen that device PEFR. We ask the patient to blow into it. After three readings, we check the maximum reading. This is peak expiratory flow rate, the cylindrical device. We ask the patient to do that BD twice a day for 2 to 4 weeks. And if the difference between minimum and maximum value is more than 20%, then we say this peak expiratory flow rate is positive. So the difference is basically it is the variability. What is the reading in the evening? What is the reading in the morning? If morning is like low, evening is high, and the difference is more than 20%, then we say this test is positive. Other test, direct bronchial challenge test. So bronchial challenge test is basically the opposite of BDR, bronchial uh, bronchodilator reversibility test. In BDR, we dilate the airway, air tracts. In direct bronchial challenge, we kind of uh, put some allergens, introduce some allergens to constrict it. So usually the uh, allergens or the substance we use is histamine or methacholine. What this will do, it will cause drop in FEV1 and that drop is basically provocative concentration causing a drop of 20% in FEV1. And if we measure the value of provocative concentration PC20 of 8 milligram per ml or less is positive. We don't need to remember this. Useless. We just need to remember direct bronchial challenge test is the opposite of BDR. And if BDR is negative and if PEFR is negative, we still need confirmation. We will go and perform this test. Skin prick test used to assess atopy. We introduce the allergens in the skin. After 20 minutes, we check the wheal size. We don't do it anymore. So leave this. Now we know chronic asthma. Let's make the picture here. So yeah. So in chronic asthma, we have discussed exactly what is it: airway inflammation, airflow limitation, and then airway hyperresponsiveness. We have seen clinical features. Usually the MCQ come from hyperinflation, increased residual volume, and then worsening shortness of breath, cough. In diagnosis, pheno, spirometry, BDR, peak expiratory flow rate, direct bronchial challenge test, and then skin. We don't use skin now. Now, if we go to nice guidelines, they say let's discuss the diagnosis in adult. To be honest, if you look at this, there is no green area in this. It means out of multiple preparation material, there has not been a single MCQ from this area. Yeah, but again, there is a diagnosis table for age from 5 to 16 and then less than 5-year-old child. I have not included that because it is not required. We should know. Usually it will help to understand the diagnosis bit as well. Oh, sorry, the management bit. What nice guidelines say: first do pheno and spirometry in adult, and then do BDR. If we still uncertain, then add bronchial challenge with histamine or methicillin. This is the order, but their table starts with spirometry first, then BDR, and then pheno, which which is very difficult to remember because the order should make sense on the table. So I have kind of rearranged the whole table and I have simplified most of the things we don't need. I have removed few lines there. So let's say now we know all the tests. Let's apply. Pheno, more than 40 parts per billion, positive, and then 25 to 39, suspected area. Because if I say less than 25, it means we don't need to go below. Less than 25 means we need to consider other possibilities. These symptoms are not from asthma. That could be a third link that I haven't included. So let's discuss the right side of tree. So based on their flow, pheno, then spirometry. Pheno is positive more than 40 or equal to 40. Then we did spirometry. Spirometry can be obstructive, can be restrictive or non-obstructive. If we move forward from their line, then add BDR test. BDR The bronchodilator test, we will give beta agonist or oral or inhaled corticosteroid to see 12% improvement, 200 ml, all those things. After BDR, if BDR is positive, now we got BDR positive, spirometry obstructive picture, and FeNO is also more than 40. Everything is checked, asthma diagnosed. But if we get FeNO positive, spirometry obstructive, but BDR is negative, we need to suspect asthma, but we don't need to label it as asthma for now. But then obviously we can refer the patient to specialist clinic, or we can do peak expiratory flow rate here, and then we can do bronchial challenge, but that is not required for the purpose of exam. If spirometry is non-obstructive or negative or restrictive, it means FEV1 by FVC is more than 70%. Then we need to do peak expiratory flow rate. Now, the interesting thing here is if spirometry is obstructive, it means bronchoconstriction. The next test we need bronchodilation. Makes sense. If spirometry is non obstructive, then we don't need a test for bronchoconstriction, bronchodilation test, BDR test. Then we need the other test, which is peak expiratory flow rate variability. We will ask the patient to take BD readings for 2 to 4 weeks, and then we will see the difference. If it is more than 20%, as we discussed above, asthma is diagnosed. If it is less than 20%, then we will go to next step. So we need to keep this whole thing FeNO 40, spirometry non-obstructive, and then we went directly to peak expiratory flow rate. And if we are not able to find anything on this one as well, we will jump to direct bronchial test, challenge test. Just a second. What happened here? Technology is only good if it works. So okay, so yeah, now it is working. So we have studied this side of the tree. If FeNO is positive, spirometry obstructive makes sense. BDR. If spirometry is negative, PEF. PEF is positive, asthma. PEF is negative, next step of test. Because there are two tests, that are negative, only one positive. We need to get another test to support our diagnosis. If challenge test is positive, then we will say asthma is diagnosed. If it is negative, not asthma, consider other thing, because now 1 2 3 tests are negative, only one positive, it cannot be asthma. Moving on to the other side, FeNO is in the suspicion area, fractional, expired nitric oxide. And next step is do spirometry, obstructive, non-obstructive. If it is obstructive, we remember, if there is obstruction, do the test of dilation, BDR. If BDR is positive, we need to suspect asthma, because here the section is of FeNO part is of suspicion, and BDR and spirometry is not sportive. So we can suspect asthma here. If you go through the guidelines, they also mention we can do peak expiratory flow rate in this bit, which will also be negative. That's why with this and peak expiratory flow rate, they said to go for suspicion rather than diagnosing asthma. With this suspicion, usually we treat the symptom, we refer the patient to specialist. For our exam purpose, we don't need to remember. The only reason I'm putting so much time on this table so that if you look at other tables, it will be very quick for you. So spirometry, suspicion area, non-obstructive. If it is non-obstructive, we don't need to do BDR. We will jump to peak expiratory flow rate variability. If it is positive, next is bronchial challenge test. Now you have seen the difference. If spirometry was negative, peak expiratory was positive, we diagnosed the asthma. Because there was one positive, the other one was positive. If here, after peak expiratory flow rate was positive, we have jumped to next test, bronchial challenge test. If that was positive, we have gone with the diagnosis of asthma. It makes sense because there is suspicion. This is also not sporting. So there has to be two tests to help us make the diagnosis. If peak expiratory flow rate is negative, now there are three negative. One, suspicion, not sporting, peak flow is also negative, alternative diagnosis. And same from here, if bronchial challenge is negative here, then alternate diagnosis because bronchial challenge is negative, spirometry is negative, pheno is negative, only peak expiratory flow rate cannot support the diagnosis. So I have marked this whole thing in blue, all those lines which can help us diagnose. All the oranges are basically the step of introducing the new test. The yellow one is basically suspicion pathway. We will treat, maybe help to get help from asthma specialist. So we will quickly see diagnosis. Asthma diagnosis, three test positive here. In spirometry, negative route, peak expiratory flow rate and pheno is enough. If peak expiratory flow is not supporting, we will add bronchial challenge test. So from here, obviously we have discussed this part. So now let me quickly. So this is the whole thing. We will jump on to management now. It was acute asthma. We know the symptom. We know the types, near fatal 25, 50, 100. And then we remember this triangle to memorize all the symptoms, near fatal, normal, or raised. We know the management, oxygen, salbutamol, steroid, 40 milligram of uh, prednisolone, salbutamol 2.5 milligram, ipratropium 500 microgram or 0.5 milligram, magnesium sulfate 1.222 gram IV over 20 minutes, and then aminophylline, usually 5 milligram per kg, but we don't need to go to that route. Occupational asthma, history will be worsening symptom at work, during weekdays, on weekend. We all know most common isocyanate. The only thing we need to remember is we need to do serial peak expiratory flow rate. Tough variant of asthma. The only thing we need to remember, all the tests will be normal. Patient is waking up at night, cough, wheeze. What we need to do, give trial of high dose steroid. Chronic asthma, chronic inflammatory disorder of airway hyperresponsiveness. And clinical feature, we know wheeze, chest tightness, cough, which is dry, and then worsening shortness of breath. If we talk about signs, eczema, we can see in the on the elbows. Nasal polyp, if someone is aspirin sensitive, we can also on examination expiratory polyphonic wheeze. Hyperinflation of the chest on chest X-ray tachypnea, which will be visible. Diagnosis, we know pheno, we know spirometry. Pheno 40 for adult, 35 or above for children. Spirometry FEV1 divided by FEC less than 70%. Restrictive, we know now why restrictive. Oh, sorry, less than 70% obstructive. We know why obstructive. Then BDR test, we will give agonist, improvement more than 12%, 200 ml of volume expansion. If volume expansion is 400 ml, suggestive of asthma in children, 12%. Variable peak expiratory flow rate, we will ask the patient to do BD for 2 to 4 weeks. We know now. Next test was a direct bronchial challenge test, which is opposite of bronch bronchodilator reversibility test. We kind of introduced allergens to constrict the airways, and we have seen PC 20 of 8 milligram per ml or less is positive. It will be too much to go into detail of that. Never mind. Next test is hyper responsiveness test. Basically, that was the last pillar of the asthma, chronic asthma. Limitation, spirometry, peak expiratory flow, and then inflammation, airway inflammation, which was diagnosed by Pheno, and the last one is hyper responsiveness. Third pillar, we will test that pillar with this direct bronchial test. So, yeah, diagnosis, we have discussed this table, which makes sense. Now, moving on to the most important bit for us, management. The MCQs will come from management. Before we jump into management, let's discuss these terms which will come in the management at some point. What is MARD? The basic idea of chronic asthma management is on each step of the severity, there are two things. One is maintenance therapy, the other one is reliever therapy. Okay. In maintenance therapy, patient will be on something regular, and reliever therapy, if he needs something as needed, PRN as required, there should be something there to help him on top of the regular thing. So this is basically the whole idea of chronic asthma management, long-term management. MART is basically maintenance and reliever therapy together in one package. In MART, we get ICS, inhaled corticosteroid, plus LABA, which is fast acting. So this whole thing is MART. Okay. Now we can give ICS and LABA without MART. It means we are giving them separately as a fixed dose. Patient is taking some ICS, a beclomethasone, budesonide. LABA is salmeterol. So patient can take them separately. They should not be the part of MART. But we will discuss in the management why we will choose MART over separate uh, ICS or LABA. So now we know MART, and again, so this screen is not stuck basically. Something here. Okay, so that will trigger it. Okay, now the other thing is we try to remember these terms: SABA, LABA, LTRA, MART, and MCQ usually come from patient is taking salbutamol, fluticasone, salmeterol, budesonide, beclomethasone, montelukast. What you will do? Then it is usually very difficult if we don't remember what is what. SABA, we know SABA is salbutamol. LABA is salmeterol. So we know this is short acting beta agonist, long acting beta agonist. ICS, inhaled corticosteroid, beclomethasone, budesonide. LTRA, leukotriene receptor antagonist, montelukast is the example. And in MART, we have discussed ICS and LABA will be there in MART. Now there are multiple example of MART, that commercial product that we can buy in the store. Fostier, Symbicort, Durest, Seretide. We will see Seretide usually in the question. Seretide is a combination of fluticasone, which is ICS, and then salmeterol, which is LABA. So this whole package is MART. So Durest is budesonide, formoterol instead of salmeterol, formoterol. Again, Symbicort is same combination. The dose is different, 160 or 164.5. Fostier is not budesonide but beclomethasone and formoterol with 160. This is just we know when we are going to next step what we are talking about. So let's discuss the final step of asthma for MRCP part 1 is management. Step 1. I have put step 1 here separately. So if someone is with normal lung function with some intermittent wheeze, their life is not getting compromised. We only need to give SABA. What is SABA? Salbutamol. We will also discuss this management with the medication so that in MCQ we can also think from that perspective. So every step should have two things. One is maintenance therapy, the second is reliever therapy. Every step. That's the reason I have put this step above these two, because if someone is not requiring proper treatment, he only need reliever therapy and not the maintenance therapy. Moving on to step 2. So yeah, so let's discuss step 2. If someone is not getting better with salbutamol, next step is to add low dose inhaled corticosteroid, which is beclomethasone, budesonide, as we have discussed. Example. This is the maintenance dose. It can be beclomethasone 200 microgram BD based on the severity. It should be low dose. And reliever therapy, SABA. So for now, just remember reliever therapy is always SABA except few steps. I will tell them later. For now, don't try to remember SABA in the reliever part. Consider reliever is always SABA. So in first step, patient is not needing anything, reliever therapy, SABA. In second step, patient is needing low dose ICS, reliever therapy, SABA. Now, low dose inhaled corticosteroid and SABA, and patient is still getting some issues. What are the issues? Here are these issues. If patient is getting symptoms 3 or more than 3 per week, if patient is waking up during night more than once or once during week, and SABA is basically not enough for the person, then obviously we will move from step 1 to step 2. This is basically the criteria to add low dose ICS. The next step is low dose ICS is already there. We need to add another agent which is LTRA, liquid trine receptor antagonist, which is montelocast. Now, here is some differentiation. For the purpose of exam, we will remember this LTRA, which is a nice guideline. The BTS guideline says instead of LTRA, we should try LABA first. Yeah. So to remember this, LTRA is Montelocast. Suppose which is a cheaper drug, they want some low dose ICS along with cost effective, cheaper in a sense, cost effective drug first to control the symptom. So that's why how I remember what is next, LTRA, because it is cheaper to buy. I don't know the price though. Next step is low dose ICS. I'm not talking about reliever therapy, but it is there in every step in with LTRA and next step. Next step, which is the fourth step, low ICS. We will introduce LABA here, but we can continue LTRA, which is Montelocast, or we can stop based on how the patient was feeling with the Montelocast. Next step, we will take low dose ICS. We will also take LABA from the last step, but we can introduce them as a MART regime. So that's why I thought we should discuss MART first. We can give ICS and LABA separately, but with MART regime, it will be a single thing like Fostair, Symbicort, Diores. Patient need to inhale a single thing, and that will be easier for the patient. Plus minus LTRA. So now we can see LTRA is basically if patient is okay, maybe you can give, patient is not feeling anything, you can remove it. Next step is moderate dose ICS LABA or fixed or within MART plus minus LTRA. Now look at the pattern here. Low dose ICS, step 2, step 3, we added low dose ICS with Montelocast LTRA. Fourth step, low dose ICS, we have added LABA. So now there are three drugs if patient is okay with LTRA. This is, to be honest, all that we need to remember. Low dose ICS, low dose ICS LTRA, low dose ICS LABA. Fourth step. Fifth step is the same as fourth step. Instead of giving ICS and LABA, we are giving them as a MART regime. Plus minus LTRA. In MART regime, on fifth step, we were giving low dose ICS. If there is no improvement, we will jump to a MART regime in which inhaled corticosteroid will be of moderate dose. If I give you an example for budesonide, 400 microgram, less than 400 microgram is low dose ICS, more than 800 microgram is high dose ICS, and from 400 to 800 is moderate dose, but we don't need to remember that. Now here you can see moderate dose, moderate dose ICS. Uh, just a second. Okay. So now, so moderate dose ICS or LABA can be given in MART or fixed, not specific. Now, next step, I have divided these steps into a single step with three sub steps, 7A, 7B, 7C. Now it is very easy to see. We only need to remember three steps basically. Low dose ICS, low dose ICS with LTRA, low dose ICS with LABA. These are the three steps that we need to remember. Next step is the same low dose ICS with LABA but within MART, and next step will be increasing ICS from low dose to moderate dose in MART. Plus minus LTRA and plus SABA is coming there. Okay. Yeah, good. So if I bring it here. Okay, where were we? So yeah, we were here. Now the last step is, if moderate dose of ICS is not working, either we can jump to high dose of ICS plus LABA as fixed, not within MART, or we can keep moderate dose ICS and LABA within the MART, and we can add another drug which can be LAMA, long acting muscarinic antagonist, or aminophylline theophylline. This is the other variation. The last variation is seek help from asthma specialist. So from step 6, we can jump directly to either step. So from moderate, either change from MART to separate LABA and high dose, or continue the same step 6 and add another drug, or seek specialist help. So this is the whole management for asthma, chronic asthma. Acute asthma management is different, entirely different. Oxygen, salbutamol, steroid, ipratropium, IV magnesium, aminophylline. And this is entirely different. It has two parts: maintenance therapy and reliever therapy. Now, the one thing I need to tell about reliever therapy is, when we start MARD at step 5, the beauty of MART is it can be maintenance and reliever therapy at the same time. That's why we prefer MART. That is single thing. We just tell the patient, take it regularly. If you need it, you can take the same thing. But if we go to the moderate dose of ICS in the MART, either we need dose MART, low dose ICS MART, or SABA as a reliever therapy. And that will be true again if we continue from 6 step to 7B, which is continue step C plus added medication. Then the reliever therapy will also transfer here. So now let's quickly review. I'm going to talk now with the medications. Yeah. Step number 1, patient is on salbutamol only. Good. Step number 2, patient, why we have jumped up to step number 2? Either patient is getting symptomatic 3 or more times, or waking up at night once a week or more than once a week, or SABA is not enough. We have jumped to step number 2, which is budesonide or beclomethasone. For this, suppose we will remember beclomethasone only. Beclomethasone, reliever therapy, salbutamol, not helping, jumped up. Beclomethasone plus montelukast, reliever therapy. SABA, not helping. Beclomethasone, LABA is salmetrol, formoterol, and plus minus montelukast. And then obviously MART, 5 or 6 is MART. We know the name of MART. We can introduce MART here. At step 5, it can be reliever therapy and the other therapy. Suppose we give patient here seretide, which we will see in most of the questions. Seretide, patient is on seretide, take seretide if you need it. As a reliever therapy, you don't need to do anything. So that's why it is very easy. Remember low dose ICS, low dose ICS LTRA, low dose ICS LABA plus minus RTA. These are the 3 steps we need to remember. And then we know low MRTA, low MART and moderate dose MART. From moderate dose MART, beclomethasone, formoterol. Here, seretide as reliever and as maintenance. Seretide with high dose, maybe we need to change from seretide to Diores, which has more ICS. And from moderate, we can use reliever as low dose ICS smart, which is Siritide or Saba. And from sixth step, we can jump to either of these steps. High dose ICS plus LABA as fixed, not as smart. And obviously, we can continue the sixth step or seek help. So this is the management in adult. So there is slight variation if this is age 17 or above. Slight variation if the patient is a child less than 5 year old. We straight uh, jump to moderate inhaled corticosteroid dose, which is ped related moderate ICS, not the adult one. We give this for 8 weeks. Now the interesting thing is anyone who is less than 5 year old, we cannot do pheno, we cannot do BDR because child will not be able to tolerate or not as cooperative. So anything below the age of 5 is suspicion of asthma and not a diagnostic or asthma diagnosis properly. So that's why we don't know the diagnosis. We don't jump to the full protocol of chronic asthma management as we just discussed. So we give a trial of slightly higher dose, moderate dose speeds. If symptoms get better and come back after 4 weeks, keep repeating the same thing. But if symptoms gets better and then reoccur within a month, move to step 2, which is here. But if symptoms don't resolve at all with this regime, think of other diagnosis. First step is different, then all the steps are more or less the same as we discussed before. PEDS moderate ICS for 8 weeks. If symptoms reoccur after a month, repeat the same thing. But if symptoms reoccur before a month, move to step 2. If symptoms don't resolve, think of another diagnosis. Step 2, same as step 2 of an adult, low dose ICS. Here also, PEDS low dose ICS. Next step was low dose ICS with LTRA. Same here. The other thing is we don't add LABA or any other step in a child because we are not sure if it is confirmed asthma. So we try not to go through the full route of asthma. So very simple. PEDS low dose, try Montelocast, stay on PEDS low dose always. Still not improved, asthma specialist. They will decide what to do. So less than 5, give a slightly higher dose. In a month, coming back, jump here. After a month, coming back, symptoms coming back. Repeat this. If no improvement, seek specialist referral, or the diagnosis will be a different diagnosis. Always PEDS low dose ICS at each step, but in third step, we can add Montelocast. So we know age less than 5. This is age 5 to 16. Whole management is like an adult with two differences only. Except low ICS throughout this chart. So we know in each step 2, 3, 4, and then obviously in Mark, but we change the name. Low dose ICS, low dose ICS, low dose ICS. We need to use PEDS low dose ICS. And after step 6, which is a moderate dose ICS, a MART with moderate dose ICS and LABA. In adult, we can jump to either of these steps. Yeah. But in 5 to 16-year-old child, either we can do 7A and C together or 7A or 7B together. Let's see what they are. So 7A or C together, or 7A or B? 7A is high dose ICS plus LABA as fixed. Now this high dose is a PEDS high dose, and then add another drug. So we need to take these two steps together: jump to high dose and add another drug, or jump to high dose and seek help at the same time. This is the only two differences, except low or moderate adult dose we use PEDS dose, and from sixth step to seventh step, the only difference is in a children in a child we need to take two-step approach on seventh level instead of separate steps. So quickly, so now if you see the population of MCQs, the green bit, we can see the most green area is in the upper half of the management, which explains MRCP part 1 and not the advanced management. Same in the diagnosis, not as many things, so they expect us to know, diagnose, and know the initial. So, as we were discussing the MCQs that can populate in the management of chronic asthma, so we can see here MCQ related to these symptoms. A young female waking up at night, only taking SABA, what to do? Jump to next step, add beclomethasone. Again, someone is already on beclomethasone, what to do? Jump to next step, add montelukast. Hardly someone will ask about these, but we know everything. So if I go back, so here you can close the video, you know everything. But if you are someone like me, which will just continue for a quick revision, we discussed acute asthma, occupational asthma, cough variant of asthma, and then we discussed chronic asthma. Yeah, and in the last we will. So let's discuss here brittle asthma. Brittle asthma is same as chronic asthma, but patient is on steroid and his peak expiratory flow rate variability will be high. So whenever we see brittle asthma in the question, we need to expect this is a high risk asthmatic patient. Someone maybe patient will have multiple ITU admissions, patient can have multiple previous hospital admissions in the recent year. And usually, if the patient is coming with acute exacerbation of asthma with the background of brittle asthma, we will expect the MCQ to jump to magnesium sulfate level of management for us to answer rather than salbutamol or just the steroid. So everything from asthma for MRCP1. So we have done around 85 MCQs. We can see on the screen everything is written there. We have done 5 different variations of asthma. This is everything. So it has included multiple sources, NICE guidelines, BDS guidelines. Well, this is for the uh, paper only. After this, you are not still, or we are not still like a asthma specialist, or we can go and see the patient. So let's quickly see asthma. Acute asthma, we know the symptoms. We remember 25, 50, and 100, more than 25 respiratory rate in severe, and then heart rate less than 100. Sorry, heart rate less, more than 100, and peak expiratory flow rate less than 50 for severe. For life-threatening asthma, peak expiratory flow rate less than 33, And then we made a triangle to remember something in the head, confusion, confusion, drowsiness, lungs, silent chest, poor respiratory effort, and heart related bradycardia or arrhythmia or dysrhythmic or arrhythmia. Here, the thing we need to remember is this: near fatal asthma, normal or just a second. Yeah. Normal or raised PCO2, we know the management: O2, salbutamol, steroid, prednisolone, 2.5, magnesium sulfate. Important thing to remember: magnesium sulfate and all these three steps, as you can see, multiple MCQs here. So, acute bit is sorted. So, here is some random things: how Manchuri mask delivers specific percentage. We know it works by negative pressure and suck the room air into air entrainment. So we know NSAID or beta blocker. We know about brittle asthma. Usually they are on high dose steroid. And yeah, this is basically the vaccination. If someone on high dose steroid and they want to go abroad, they cannot get live attenuated vaccines, which is a yellow fever, MMR, or influenza. Moving on to occupational asthma, we know getting worse on work, they will feel better during weekend or holidays. Isocyanate is an important thing to remember. MCQs usually come: patient is working in spray factory or coating factory, or as we see, catering bakery, or we have seen soldering plant, uh, we have also seen welders, okay, and also lab animal. Management is serial peak expiratory flow, refer to specialist. Symptom can. Next, cough variant. Someone will be waking up for more than 6 7 months during night. Maybe the history of eczema or any slight history, but all the test will be normal. What we need to do: give a high dose steroid trial, inhaled corticosteroid for 2 months. So chronic asthma here. Now we know chronic asthma is chronic inflammation and this expiratory polyphonic wheeze. Chronic inflammatory disorder by hyperresponsiveness, three pillar: airway inflammation, airway hyperresponsiveness, airflow limitation. And then jumping on to clinical feature, we know all these. The thing to remember is hyperinflation. Sometimes you can come with increased residual volume and worsening dyspnea. Cough, wakes up at night, dry cough on exertion. What is the diagnosis? Asthma. Diagnosis: we know pheno, fractional exhale test, spirometry, we know BDR test, we know variable peak expiratory flow. Young female, dry cough, wakes up at night. Most useful test is airflow limitation, which is spirometry. And we know direct bronchial challenge test with asthma. So here is the tree. Pheno is positive, jump to spirometry, jump to, if it is positive, BDR, if it is positive, asthma. Spirometry negative, then PEF is positive, asthma. Pheno is negative, spirometry is positive, good. Only one test is positive, this is suspicion. PDR is negative, PFR is negative, everything is negative. Then challenge test is positive. So with suspicion, we can go to asthma diagnosis with all these tests. But obviously, we don't need this area. So again, pheno suspicion, spirometry non-obstructive, peak expiratory flow positive, bronchial challenge test is positive, asthma is diagnosed. So we will jump back to management bit. So we know 17, 5 in 5 moderate dose ICS for 8 weeks. If symptoms reoccur within a month, move to step 2. If reoccur after a month, repeat the same dose. If no improvement, consider a diagnosis. Always keep the child on PEDS low dose ICS apart from step T where we can add montelukast. So let's quickly repeat this. Patient is on salbutamol, no help. Patient is on beclomethasone and salbutamol, good, no help. Patient is on beclomethasone, montelukast and salbutamol. Patient is on beclomethasone or formoterol or salmeterol, montelukast, no help. Change to MART, single device. Diores, Foster, all those things with low dose. Reliever therapy will be same. Moderate dose MART are also available, but we need to keep reliever therapy at low dose or SABA. From here, step 6 to we can jump to either step, which will be low dose ICS or LABA in step 6. Step 6 moderate dose ICS plus LABA to high dose ICS and LABA as fixed and not as MART, or add LAMA or theophylline, or add refer to specialist. From 5 to 6, only difference is except low dose we use PEDS low dose, and also if it is moderate dose or high dose it will be PEDS moderate low dose or high dose. And after step 6 we cannot jump to individual test as in adult. We need to jump from a 6 to 2 of step 7AC or 7AB, which is high dose ICS plus any drug, or high dose ICS LABA plus specialist. Thank you very much.